Alright, so here I am working at the crest, and the contact is at the bone. It's a soft fist. I'm working from anterior to posterior, and I'll show shortly on the skeleton how literal that description is to work up against the bone. And as we cross along that region of the lower waistline, it's useful to remember all the various myofascial structures that we're affecting. The thoracolumbar fascia, portions of the erectors, some of the fibers of latissimus, obliques, possibly some of the fibers of transversus abdominis, and some of the fibers of the quadratus lumborum. And that makes it a very highly economical area to make contact, because the effect goes into all those structures, as well as the contact on the periosteum of the bone. Moving towards the posterior portion of this, and it becomes increasingly difficult to stabilize my hand there. It just feels like I'm dropping off, which I'll exaggerate slightly, and that means I'm really done with that. I'll go through the movement again, and I'll ask Victoria to participate with some movement, and the movement can be as simple as just to begin with letting the tailbone back slightly, so just reaching back with the tailbone. Now we know that for us, if we speak in kinesiological terms, we're talking about anterior tilt as the tail comes back and then the other way, just letting the tail forward towards the wall in front of you, and there we're getting the posterior tilt. I'm always looking for ways to describe those movements in terms of a direction with a body part. My hand can guide that movement, so just once again reaching back with your tailbone. And once again forward. Good. And then letting loose of that. And one thing you can explore there is that deeper sense of neutral, or allowing your body to receive the sensation of the pressure of the table and the support of the table. And as you do that, you might feel that you can receive the pressure of my arm inside your pelvis a little bit further. Like that, and once again I'm approaching that area where I feel like I'm going to fall off, so I'll just maintain the contact for as long as I can, and now it's just about so vertical that there's not much else I can do there. In the release that we've been looking at, the contact is very deliberately against the bone. And like many of the things we do against the periosteum, it's a very pleasant feeling when it's done well. And one of the ways to do it well is to make sure that there's not overpressure and you're creating a bracing or a guarding effect. If I palpate the greater trochanter, and then I feel also then for the crest, and draw a line between the two about at the midline of the crest, I'll be right over the top of the gluteus medius. If I palpate forward of that line, which is what I'm doing now, and I feel for the ASIS along the front of the ilium, and palpate inferior of that, so now I'm in front of the trochanter, I'll be able to feel parts of the tensor fascia lata, and that's a very strong hip flexor. It's a tonic muscle, and quite often as a tonic muscle it will be short and fibrous and hold the pelvis in anterior tilt, so it's always worth palpating and assessing to see if it deserves some release. I'm going to show the release here on Victoria even though it doesn't feel particularly hypertoned, and going to work with an elbow, and I'm going to land and sink in that area that I've been describing. And with this I'm going to explore the vertical compressive stage of the release for longer. And there's the response, and the response is a reduction in the guarding and then an opening out of the muscle, so a fairly noticeable change in the tone, and it feels now that the pelvis is less bound and less controlled, and this is useful. At this point, I'm then starting to add a little bit of inferior or distal drag through the tissue, and I can do that through the clothing. And this is the tensor fascia lata, a strong flexor of the hip. You might even be able to see some of those fairly rapid changes in position of Victoria's pelvis as she releases some of the tensioning around the hips. It does somewhat bring to mind the old, I don't know if it's a maxim or an aphorism or what, that you don't have to feel bad to feel better. So quite often the fact that there's not a positive outcome, or it's not a positive test on the Ober's test, nevertheless that people will still experience really very deep relaxation and decompression through their system without there being any obvious shortness or restriction in the range of motion. And that would seem to be what's happening here. Once again, I can ask for a movement from Victoria, so I just ask her to reach back with her tailbone a little bit. And that's good. Very nice. That's nice movement. It's smooth, not too jerky, and she's not kind of bolting with the movement like a bolting, meaning abruptly sort of starting out with a great deal of effort, but rather nice, easy, no abrupt movement, smooth, mindful motion, and that's what we're encouraging in our clients, that connection to the mindfulness of the motion, sensing where they are in space rather than just moving without much awareness. Good? Oh, the initial contact has been at the crest. Now I've moved in on top of the tensor fascia lata and followed that down towards its blending in with the iliotibial band. Next I'll work right on top of the trochanter itself. I'll just fold Victoria's shorts up here slightly so we can see the top of the bone there. This is the trochanter. Going to use my elbow, quite similar look to what I was just doing. Once again, there's a compressive component or a landing, but not far to go here because I'm over the top of the bone. Sinking towards the floor, taking up a little bit of tension in the tissue, and then gliding towards the knee. So once again, the movement is distal. And very deliberate contact against the periosteum. With the periosteum, it's important not to overpressure. We know that the periosteums can be quite tender and very sensitive if it's worked on abruptly. Anytime we're working with sustained pressure against the bone, we want to apply the pressure, increasing the pressure slowly, and making all the time sure that we're not inducing any reactive response, which is a guarding or constricting. And done well, this deep pressure onto the periosteum is almost or universally received as being very pacifying and relaxing. You can see I've moved down the leg a little bit, so I'm kind of moved away from the trochanter, and now I'm a bit more onto the side of the femur and starting to pick up portions of the iliotibial band, and that's how this whole release will continue. So with the trochanter, it's the same thing. We want to be able to confidently contact the greater trochanter. I was working with my elbow, but I'm showing here with my finger, and we're spreading the tissue in a sense around the bone there, and there's contact made with the underlying periosteum. And the same when we're treating the IT band, that once again it's very easy to access contact all the way through to the periosteum at all these points. So I'll pick that up, this contact up again at the trochanter. And now I'm going to take the work along the iliotibial band, and the iliotibial band has often worked in therapy, and it's a structure that often warrants quite a bit of input. I'd suggest that it responds better to slow and methodical release of this kind rather than anything too aggressive or violent. A lot of people have had the experience of having received work on their IT band, and they've found it to be rather excruciating, and I don't think there's any real need for that. I think if we work slowly and we work mindfully, we're going to have better outcomes than if we just try to aggressively strip through this section of the leg. So I'm following that standard protocol at this point where I'm landing. I'm going to switch arms for a moment and talk to the camera a little bit. I'm following that standard protocol of landing and sinking. So there's a compression, and then I'm also putting a tension in the tissue and working inferiorly. And a nice movement again would be to have Victoria, I'll ask Victoria to just move her tailbone back. And forward, so she's just getting a nice easy rocking motion through the hip joint while I'm pulling on the IT band. Once again, feeling for the underlying periosteum, so it's not just the soft tissue, but it's all the way through to the bone. Good, and rest there. I'll do some with my finger just so you can see, I can describe more accurately the vectors, landing and sinking, so that you can see the compression into the tissue, taking up the tension in the tissue, and working from proximal to distal. I think I can detect that of all the regions that I've worked, or the region or the length of the IT band so far, that this distal portion has some palpable fibrous change, but very little. With some people, this bottom third will feel a bit like the lunar landscape. It's so topographical. Feels like you're riding up and over craters, pile up of collagen fibers, and often quite dried out as well, so fairly ropey, dried out, stringy tissue. As with most of our contacts, we'd like it to go through the length of the soft tissue and then carry that across onto the tibia. So it is the iliotibial band, and so it makes sense to follow it across to the bone and even slightly beyond that. And that could all be done with my elbow. So I just restate, I've been doing that with my fingers just so you can see more of the vectors, angles, pressure. This work can also be done quite nicely with a fist. Working now at the hamstring and dividing the hamstrings really into two sections. The first section is the medial, the hamstrings, so the semitendinosus and semimembranosus. And I'm starting out here working with my fingers, and that's so you can see quite clearly where it is that I am working. And I'll describe my relationship with the mass of the tendons there, and that is that because I'm using 3 fingers, I'm over the top of the tendon, so that's directly, there's compressive force into the tendons themselves. But my first finger here, index finger, is slightly lateral of that tendon, so I'm able to sink into the space that's there between the medial hamstrings and the lateral hamstrings, or the biceps. And that's how this would look with my fingers. And directing that up towards the ischial tuberosity, so the underside of the pelvis. I will also work this very often with my elbow. And that, of course, is a fair big change in the amount of contact I can make and the amount of pressure that I can bring into the work. Now, a useful movement that I can ask for with Victoria would be to just lift her tailbone towards the ceiling and elongate her heel away at the same time. So we're getting this lengthening from the underside and also lengthening by lifting the tuberosity. Feeling good and letting down. I'm working up in that manner, and I'll divide the leg into 2 sections to do that. So not only have I divided it into lateral and medial hamstrings, I'm also dividing this into a couple of sections. So I'll just pick this up again where I finished off last time and continue to carry that work superiorly, making sure that I keep the contact following the line of the muscles towards the tuberosity. So I'll do something shortly. I'll work more into the posterior portion of the adductors. For right now, I want to keep things moving towards the ischial tuberosity, which is here. So I can palpate that bony prominence on the underside of the pelvis and direct my contact towards it. Like many of the areas where we have this convergence of tendon and bone and ligament and fascia, the underside of the pelvis at the ischial tuberosity represents a very useful site to keep a contact against while I ask for movement. Here the movement's going to be little because I've got a lot of pressure up against the bone here. So I am just going to ask Victoria to lift her tailbone slightly and then take it down slightly. And this is self-mobilizing while I apply a fairly consistent force just on the underside of the tuberosity there. And progressively what I'm noticing is as Victoria makes that movement, the coordination of the movement, in some ways the strength of the movement is increasing, so she's able to explore some neuromuscular kinds of integration while I provide the pressure there, and that's quite often assists a great deal in starting to open out that underside of the pelvis and that distal portion of the sacrotuberous ligament. Okay, to work with the medial hamstring tendon across the back of the knee, and this is a little bit like what you've seen for working around the top portion of the gastroc. I would often work from the opposite side, but for the convenience of this videoing, I'm standing on the same side. I have long arms. I can turn this corner fairly readily. Some people I notice in classes, this is not so comfortable in their body, and they find that working across from the opposite side so that they can really angle on, once again we want to angle onto the bones. If they're coming from the opposite side, that just facilitates that contact. Can also ask Victoria, which I will, ask her to just push her knee slightly into the table. So just pushing down to the ground with the knee, and that's using somewhat the flexors, some contraction in the flexors, and that will help relax the muscles in the back. And also pushing down in the knee and elongating through the heel at the same time, and there's a slightly more complicated movement. Good, and letting loose of that. Good, good. Once again, just the reminder, staying out of the soft pad in the very back of the knee, just working deliberately, in this instance, the medial side of that pad, the neurovascular bundle there. This time it will be the lateral hamstrings, the biceps femoris, showing again with my fingers, straddling the tendon itself, as well as working in the seam between the biceps and the semis. And with this work, and really with all of the work that I'm showing, these are guidelines to the areas that I'm working on. If your fingers and your elbows and knuckles detect that the tensions and the restrictions lie somewhat off these sort of more predictable lines that I'm drawing here, then I encourage you to follow those and work with what presents itself in the situation in which you're treating. But here's a nice basic line of inquiry, if you like to put it that way, for the biceps. Just asking Victoria to take the knee slightly in towards the table, just pushing the leg towards the floor, that's good. And relaxing, yep, good. And as always, the elbow provides a lot of broad contact, and it enables me to bring quite a bit more force, and curiously, because the force is spread through the broader contact, it often feels more pleasant than the more specific contact of the fingers. We know that the hamstrings are almost an epidemic of hamstring tightness in at least in Australian culture, and I suspect a large part of that comes from sitting. We spend a lot of our life in chairs, and there just seems to be an ongoing shortening of the hamstring occurs. And there's that line taken a little bit more rapidly up towards the ischial tuberosity and slightly over the top of it. It's the same for the lateral hamstring, just finding the bicep tendon and then taking the contact from superior to inferior, tracing, or not tracing, in fact it's quite literal contact across the back of the knee, and then finding my way onto the posterior portion of the fibula, which is where the hamstring terminates. But then, because I am interested in the continuity of fascia in the body and the kind of connectivity nature of that connective tissue fascia, I'll carry that a little bit past that also, and I could ask Victoria for a little bit of heel lengthening while I'm doing that. Good. And rest. So if I palpate at the top of the hamstrings and locate, once again, with certainty the ischial tuberosity, and then I move medial from that point, I'll be able to work into the posterior aspect of adductors, and I'll show that initially just with my hand where I'm directing that contact. And I'll do the release with my elbow, but I want you to see the hand and where that contact is directed. Then with my elbow, I'll sink. So the vertical, remember there's always the compressive phase, sinking towards the floor, or this is our kind of initial entry into the tissue, and then I'm going to take up a tension in an inferior direction. So I've got those two forces at work, landing, sinking, and then dragging. And there's the tension. You might be able to see that as I pull my elbow. I'm not gliding over the skin. All I'm doing there is tensioning the tissue, and that's the application of the shearing force. And then one of the things I can do here to open the tissue is to ask Victoria to make a movement. So she could just lift the tailbone slightly, yep, and the heel would also, good, and then have Victoria take the tailbone in the other way, relax the heel, and all the time I'm pulling that tissue from superior to inferior, so still going that way. Okay, and I can follow that line down about half the length of the leg. Okay, thank you. Working with the inner aspect of the thigh adductors, we can start the treatment right at the adductor tubercle. The pads of my fingers in this instance are resting quite deliberately on bone, and then I'm essentially rolling towards the table, keeping that compressive force there, taking a tension up, and you can see the way that that creates a very obvious change in the contour of the skin. So I'm landing, sinking, taking up that tension, and now I'm starting to work my way superiorly The adductor area can be very guarded, and if we work into it too quickly, we'll often find that our clients aren't too happy. One of the ways to be sure that we don't create a response, an undesirable response of guarding and muscle tension, is to think of working through a more superficial layer initially, and then come back and work through the same areas but feeling more deeply down into the underlying structures. And that's what I'm doing here with my fingers. and just posterior of the gracilis. And as always, just the reminder that we could say that the enemy of depth is speed. Here we want to be sure that our speed is, we slow the work down, gives the person ample opportunity to explore the sensation, release into the sensation, and also enables them to offer up or make available the deeper layers. So that happens more organically rather than feeling that we have to force our way towards those deeper layers. More of an unpeeling that takes place, and it's definitely a function of time. In this position I'm able to use my elbow as well, and that can still be superficial. So you'll see I've worked the bottom 2/3 with my fingers. I'll work the top third with my elbow, but I'm still going to keep the intention superficial. And I'm taking this work superiorly until I feel the underside of the ramus, or that bony surface of the ramus where the adductors attach, well, particularly magnus, of course. And at that point it becomes probably fairly difficult to see the detail of what I'm doing. So we'll come back to this in a moment. I'll just go back into what I started with, which was the work that was done systematically through that adductor compartment. And while I won't treat it in detail, I just point out that I might want to go back and work more deeply on a second or even a third set of contacts. And that might be done with my elbow the next time, and still working very slowly. Yeah, so I've sped this up just slightly because I'm not going through the whole sequence. Just landing, sinking, showing you the basic sense of coming back through the same region, working with the next level of availability in the tissue. I do want to show you the work at the pelvis, and I'll show it through Victoria's shorts here, and then we'll look at the skeleton in a moment. I can do this in two ways. One is I can just use the pads of my fingers by taking my hand down into the adductor compartment towards the table and towards the floor. I can push, so that's pushing laterally into the leg, and then if I take my fingers then superiorly, quite easily the tip of my middle finger is up against the bone. And this is somewhat an exception to our land, sink, hook and drag protocol, because at this point I'm not dragging, I'm simply maintaining that compressive contact against the underside of the pelvis there. And I'll hold that for 1 to 2 minutes. And what I expect, and what's a consistent outcome of that, is a very distinct sense of relaxation through the highest portions of the adductor muscles, as well as what appears to be a normalizing from my experience and the reports from clients over the years, a normalizing of tone within the pelvic floor. So some reflexive effect going superior from there, so up into the area of the pelvic floor, as well as affecting all those fascial tendinous structures that lie right along the ramus of the ischium there. I'll make that contact in 3 places. So here I'm moving along, starting over near the pubic bone and working my way along the ischium until my last contact will be on the underside of the ischial tuberosity. So the inferior aspect of the ischial tuberosity. And this is how I'd work with my fingers. The next contact was going to be broadly with the elbow on the underside of almost the entire ramus of the ischium. And so I'll take my elbow up fairly high into the adductor compartment, sink towards the floor, just take then my contact superiorly, and now I've got my elbow firmly and broadly across the underside of the bone there. And I can ask Victoria then to make a movement that will assist in the opening. And so I could just have her slide her knee forward and take her tailbone back slightly. Good, good. And this, once again, there shouldn't be overpressure with this. The sensory input around the underside of the pelvis, good, and have you take your tailbone the other way and your knee back. The sensory input around the underside of the pelvis should feel quite calming, quite pacifying. It shouldn't be unpleasant at all. Good, and then the other way. Good. Good. And then encouraging, once again, that deep sense of letting go and just seeing if you can let your body rest into the table more fully. Like that. And also allowing the sense of the pressure of my elbow to work into the bone there a little bit more. So you receive the pressure of the elbow in the... that's good. Good, so there's some images that you can offer people that will assist with the opening of this area, receiving the pressure of the elbow, allowing the body to be more supported by the table, giving the body, letting gravity support the body. That's often also a nice image. People suddenly find that they're able to let go of the background tension in their body. Good, and you can see that there's a sustained contact here, and this can feel very pleasant. The instruction is to push down into the adductors and then move superiorly, and you'll see that then that my fingers can then rest up against the underside of the bone, and I'm making firm contact through the rest of my hand, and that dissipates the sensation of being poked upon too much in the groin area. It makes the contact feel broad and more reassuring. And then I'm proposing that can work systematically at 3 points across from anterior to posterior until we get to the area of the ischial tuberosity. Our skeleton has an unfortunate impediment in his pelvic anatomy, in that he has a distinct sense of a rod up his rear end, but I'll be able to work around that. I'll be able to take my elbow in and show you that. Good. I'll be able to take and show how it was that I was using my whole elbow to contact that underside of the pelvis there. So I was quite broadly across the pubic ramus and the ischial ramus. And that's a really terrific contact that can be sustained for quite a long time. It's very, very useful to sustain that for at least a minute to a minute and a half, even 2 minutes, and get the client to start to initiate some of that movement with the tailbone forward and tailbone backwards, or counter nutation of the sacrum. I'll be showing 3 releases for the anterior portion of the thigh. The first one will be for the quadriceps in general, a broad release that covers all of the quadriceps. Then there'll be some work done in the femoral triangle, and so directing into that rich fascial network that lies in the femoral triangle, and finally showing some work in the seam, the fascial seam that runs between the quads, or vastus lateralis in particular, and the IT band. So I'll start with the broad work in the quadriceps. And this is how it looks. I'll be working with broad soft fist, and I'll be making contact quite close to the area of the pelvis, so that's the area of the AIIS, sinking to the level of tissue where I feel that I can make a useful engagement, and then I'm going to be putting a distal drag into the tissue, so that's towards the knee or an inferior drag, and taking up that line of tension in the tissue towards the patella. Divide the leg into at least 2 sections, possibly 3. And working that same set of protocols, landing and sinking, taking up the engagement with the tissue, which is putting it on a sustained stretch. And working towards the patella. And taking that all the way to the patella. So where possible we want to cover those myotendinous junctions and those bony tendinous junctions with our contact as well. So it's not just pressure into the belly of the muscle, but definitely specific work done close around the tendons and the joints. Secondly, to work with the area of the femoral triangle, I'm just going to abduct the leg a few degrees, 10-15 degrees, just to open out this space here. So effectively, the structures that I'm working between anatomically, just to orient you, will be the quads and the anterior portion of the adductors, so affecting pectineus as we do this. And so working medially of the mound of rec fem and taking then a contact that follows the seam effectively of the sartorius. So I'll show this with my fingers initially so you can see the precision of where you want to be landing with this one. And this is an area that's richly invested with fascia. And that's that seam traced or followed with my fingers. That's one way to work with that seam. Another way, if I elevate the table slightly, I can use my elbow in there. And curiously, that often feels to be an easier contact for the client, probably because there's less skin drag and more sense of broad pressure. So bring the table up and you can see that I'm then able to easily drop into that area again of the femoral triangle, this time with my elbow. Good. So that concludes those 2 releases, and now we'll be coming to the other side of the table to show the third one. Fascial seams, or septa. The septa where muscles get close to each other but still have some layer of fascial separation, are very fertile areas to work, very useful areas to work. And there's a number of seams that we could work in the leg. The one I'm going to show here is basically working at the edge, the anterior edge of the tensor fascia lata and the iliotibial band. But you could easily see ways in which that idea of working through seams or through the septa can be developed in any portion of the leg or anywhere in the body. Once again, I'll show with my fingers, just going to locate the band here, palpate for the band, and then I'm going to just drop my fingers in just anterior of that. And you can see that I've got quite a specific valley that I can work with here. And this is all affecting the fascia lata, which encompasses the whole area of the thigh. It's the wrapping fascia, and then some of the layers, the deeper layers that go down towards the periosteum and also separate one muscle from another. So I'm being a bit more specific. I'm affecting the broad sheets of fascia as well as working with this more specific opening on this seam here. And once again, if I was working this comprehensively and thoroughly and working to some resolution of ongoing long-term stiffness, then this would be systematic. I'd be dividing it into 2 or 3 sections and working with each section 2 to 3 times. And third area of contact. So we know that the vastus lateralis in the area of the lateral knee has a tendency to become overly toned, hypertonic, and often overpowers the vastus medialis and contributes to problems with tracking at the knee. So all of this work that's affecting vastus lateralis and the iliotibial band is very helpful as part of rehabilitating that particular problem in the knee. And once again, just wanting to underscore the need and the value of giving attention to these myotendinous, bony tendinous areas, which is what I'm doing here. So working in fairly precisely, precision, trying to feel the very local areas of restriction and give them attention. So that concludes the 3 releases for the area of the thigh. This time we're working with the hamstrings in the supine position, and you'll see that it works very well with the child because I'm able to make contact with Liam's eyes, and also he's able to see the expressions on my face, and I find this is very helpful in the pediatric setting. It's quite simple. What we'll do is just picking the leg up and positioning the hand in behind the knee, and because Liam's leg is small, my fist, my knuckles are able to cover the tendons of the biceps and the semis. I'm going to then let his knee back down and let his lower leg back down on my hand. I'll stabilize the knee, and now I'm going to start to drag towards the ischial tuberosity. And this is quite easy for me. It's just the application of my body weight with a nice easy sense of reach through my arm. I'm able to control the amount of elongation in the tissue via my left hand, which is just taking the leg slowly into more flexion whilst I lengthen out the extensors. This can also be done with adults. But sometimes you'll find that if you're working with someone of size, then it's difficult to control their leg, and it will feel a bit like a wrestling match trying to release the hamstrings from this position. But for small people and children, it's very simple.